We're starting unit 2. So a lot fewer devices, lots of medications. So remember I gave you a medication sheet at the very beginning of the class, and I was like, hey, this is for ya. You're gonna have to know some things on here, okay? All right, so as we go through, I'm gonna highlight some of the more important things you're gonna learn. The 2 medications you're gonna use the most frequently at the hospital are going to be albuterol, okay, which is often just written ALB, or Duoneb is the other one. And this is actually 2 medications, which is why it says Duo, and it's albuterol plus this weird word, ipratropium bromide, okay? So those are the 2 that you'll use the most at the hospital. You'll hand them out like candy to people that never needed them, don't have any idea why you're there, but doctors think that's a great idea. Okay, so we'll talk about those as they came up, but things you need to know before we even start, because this is about aerosol delivery device selection. So this is about picking the right device to deliver medication to a patient, okay? So this lecture today is less about medications specifically and more about what the devices are that we use to deliver medication to patients, right?
So like nebulizers, inhalers?
Yeah, so you're probably familiar with quite a few of these if you're working in the pharmacy. Okay. All right, so that's what we're really gonna talk about. So there is some terminology that we're gonna talk about, and then some new terminology you're gonna pick up on. And really we're gonna talk about how do we choose what we need for the patient, what's most appropriate. These are commonly used words in the terminology of what you're doing, okay? And we'll come back to these. A lot of these should be familiar, like aerosol or diffusion, okay? And we'll pick them up. All right, so we're gonna talk about 3 different types of deposition. So there's inertial impaction, sedimentation, and diffusion. You want me to turn this off or you want it on?
Oh.
What was that?
Oh.
Off. Is that better? Miranda's in the halo spot.
Because I'm a saint and nice to everyone.
Okay, based on conversation earlier. All right, inertial impaction. So, how many of you have ever worked in a garden? You ever dug dirt? Okay, you've dug in the dirt. Maybe played in the sand, something dusty, okay? And you get dirt like in your on your hands or gloves, right? Okay, and then you probably inhale some of it at some point, right? It gets in your nose or in your throat or in your lungs or whatever. Okay, or maybe even better is like everybody's car is covered in pollen every spring, right? Okay, so think of inertial impaction. Now remember we're talking about inhalation therapy. Okay, so this is all about what's happening in the lungs. Inertial impaction is when things collide with the larger airways. Those medications don't do us any good, okay? That's medication, well, I shouldn't say that. Those medications are not always reaching their intended target, we'll say that, okay? So inertial impaction is I'm depositing on the surface, usually in larger airways. So what are our larger airways? Larger airways. What do we got? Trachea. What comes before that?
The nose and mouth.
Yeah, so nasopharynx, oropharynx, hypopharynx, trachea, okay? And then maybe some of the main stem bronchi.
You
Okay,
said it doesn't always reach the intended area?
Correct. Depends on what your intended target is. So for example, if you have nasal congestion, your intended target is your nasal space, right? Your nasopharynx, right? But if you have small muscle or smooth muscle bronchoconstriction, that's way down here in the lungs, right? Then my intended target is the bronchioles, right? So it all depends on what my intended thing is. So inertial impaction is when we deposit on the surface. These are large particles, okay? So things you can typically see or feel, all right? They deposit because of high flow rates. You breathe in very quickly, okay? Turbulent flows in twisted airways increase impaction. So you remember when you guys did anatomy and they're like, here's your sinus, right? And you have like this big gaping hole above your mouth where your teeth are. But what's in there? Yeah, it's like all bumpy, right? And it's turbulence and it's twisted and it's full of mucus, okay? So that's what this is talking about, twisted airways. So things that cause inertial impaction or for larger particles to land on the surface of the airway include high flow rates, so breathing in very quickly, right? Turbulent flows or twisted airways. These are larger particles, greater than 5 micrometers, okay? All right, sedimentation is a little bit different. This is when aerosol particles reach the alveoli, but they settle secondary to gravity, okay? So the primary mechanism for deposition for particles that are sized 1 to 5 micrometers. These are much smaller, okay? This is mostly in the central airways, down to the smaller airways. And if we hold our breath, what happens to the flow in our lungs when we hold our breath? It stops, okay. So if I'm inhaling a particle, right? So if this is my airway, and my airway, you know, they go all different directions. If I stop and I have particles and, you know, medication, and I stop the flow, hold my breath, they settle, okay? So this is called sedimentation. So they settle on the airway, okay? So that's what this means. So if I hold my breath, the medication will settle in the airway and land there, okay?
Is that why you hold your breath after you take your, like an inhaler?
Yes, ma'am. Yes, ma'am, it is. We have other reasons too, but that's one of the main ones, okay? All right, and then diffusion is when the medicine passes actually through the alveolar capillary membrane. Okay, so that's from particles smaller than 3 micrometers, all right? Was there a particular gas that was on the test that maybe participated in diffusion that passed through the alveolar capillary membrane and caused pulmonary vasodilation? Nitric oxide does that, okay, right. So nitric oxide is by diffusion versus, like Miranda's example, an inhaler like albuterol might be by sedimentation, okay? Can you think of an upper airway disease or acute thing that we might want deposition in the upper airway?
Like if you're mucousy up here, like congestion of your nose.
Sure, so like maybe some of you have used Afrin before, like if you're having like a lot of swelling. What about in our glottic area? We talked about 2 things. One of them, I made noises for both.
Oh,
Croup was one, okay, what's the other one that I was talking about? The noise you hear in inhalation typically tells us you have upper airway inflammation. It's called stridor. Y'all looked at me when I was like, okay? So we'll go from here. Stridor, to treat stridor, we're gonna use inertial impaction, okay? I want big particles and I'm gonna breathe as best as I can, okay? For smooth muscle constriction, oh my gosh, I forgot the word muscle, okay? Or bronchospasm, we can just say that, that's a lot easier. Okay, we're gonna use sedimentation. So this is medication that I want to settle in the lower airways. And for something like diffusion, I might use for pulmonary hypertension, such as with nitric oxide, okay? So what did I say here? We use albuterol. And then for stridor, we use something called racemic epinephrine. Epinephrine. There you go. All these medications are on your list, okay? All right, so those are examples that you can tie back. We'll talk lots about them. All right, so this is just, if you're a visual person and you like colors and graphs like me, this is gonna be helpful for you. So down here, we're talking about the size of the particle, okay? How much of it deposits and where it deposits. Okay, so let's pick something we're familiar with. Let's see. Well, we're learning about medical aerosols. Okay, so medical aerosols fall somewhere between 0.1 and 10 micrometers in size. Agreed? Okay, because I'm telling you that's the truth, that you're gonna believe me. Okay, here it's highlighted for you. Okay, depending on the size, you can see that very little of it at any point, the fraction of inhaled, lands anywhere that we need it to be, right? This is only 20%, okay? But as it gets bigger, we get somewhere around 50% to land in our airways. Does that sound good? Do you follow?
Yeah.
So here's 40% or 0.4. 40% of particles sized 1.5 will land in our airways somewhere. All right? All right. What do I have written here? This is showing, okay. Okay, so anything, I was reading my notes, sorry. So anything less than this, down here, okay, this is all gonna get exhaled. So if it's less than half a micrometer in size, it's probably gonna get exhaled, right? We're not gonna do anything with that, right? All right, so here's another picture for us. All right, so aerosol particle size. This plays a huge important role in lung deposition. So it's important you understand what the particle sizes are of the devices you're using, including like any aerosol, so you know where the medication's gonna land, right? So if I was trying to give you a medication to treat bronchospasm, right, but I gave it to you in giant chunks, it's not gonna reach its intended target, right? And so the medication is of no use. If I have a patient that needs medication down here, but they can't breathe very well, that's not very helpful for the patient, right? So you gotta understand your device, how it works, where it's going, what the intended target is, okay? So almost all the devices you use are what we call heterodispersed, meaning that they make particles of a large variety, okay? They come from 1.0 to 10 micrometers in size, which means your medication does what? It lands everywhere, right? Some of it in the upper airways, some in the intended target, some diffuses through, and some gets exhaled out, okay? All right, so anything that's, greater than 5 micrometers is typically filtered out by the nose and the mouth, okay? So we lose all of that. Anything between 5 and 10, as you can see over here, really lands in the upper airways. And then less than that, 2 to 5 is in the lower airways, and anything 1 to 3 is in the lungs. Smaller than 0.5 is typically exhaled, okay? All right, the MMAD, or the mass median aerodynamic diameter, it's a fancy thing, right? This quantifies the amount of drug in the particle size distribution. So higher MMAD equals more particle sizes of a larger diameter. Okay, so what that means, if more of your drug comes in bigger pieces, it's more likely to land in the larger airways because it's heavy. Okay, so anything that's big suffers inertial impaction and gets filtered out first, right? Agreed?
Mm-hmm.
Okay, everything that's little makes its way through. Okay, so the MMAD says that the higher the number, there's more particles that are larger in diameter, and larger things typically get strung out first. All right. All right, there's different types of aerosol generators. So we have what we call small volume nebulizers, meter dose inhalers, or MDIs, sometimes written as PMDI because they're called pressurized. Then we have dry powder inhalers, and we have soft mist inhalers. And I'm gonna play with all of these, okay? Now I'm gonna go ahead a slide, and then I'm gonna come back, okay? So don't freak out. We also have small volume nebulizers that come in different types. So we have generic nebs, or jet nebulizers, that come in several different types. There's like a generic one, there's a breath enhanced one, and there's a breath actuated one. So even just saying, I need a nebulizer, could bring you a variety of things, okay? And we have ultrasonic nebs, which we talked a little bit about in our previous unit, and then vibrating mesh nebulizers, which are new. Okay, so those are kind of the big things, okay? These 4 are all handheld devices, okay? They all have 1, maybe 2, very few have 3 medications in them, but they're single patient use and they're all handheld, okay? So if you see the terms HHN, what they mean is handheld nebulizer, okay? Or they might say SVN, which is a small volume nebulizer, okay? All of those two things mean the same thing, okay? Interchangeable, same thing. All right, so a small volume nib, we put liquid in, and then we pneumatically power it, okay? And it turns into an aerosol and you breathe in. It's like magic. We're gonna talk about those. Inhalers, I think most people are familiar with, right? It's a canister, you compress it, the stuff comes out, right? A dry powder inhaler is not, does not spray anything. You have to suck it out of the device. Okay, so the patient's required to take a fast deep breath, suck it out of the device. Tell me you see two clear, see, right by them. I can't see them in the, like over the thing. Okay. So most dry powder inhalers come as a discus, not all.
Okay.
And most inhalers come like in a boot like this, okay? So you guys get to play with all of these, I promise. And then we have one more, what's at the bottom? Soft mist inhaler, is that what I see?
Yeah.
Alright, so the general rule is this shoots out of the device, okay? Like, pew! This has to be sucked out of the device, and this drifts out of the device softly, okay? See if this one's working. They've been sitting for a year, you know, so that sounds like it's, okay. Empty. Never seen one like that? Maybe this one will work. There we go. So I'm see if we can get it to. They're all empty. I think I have some more. Anyway, this is the soft mist inhaler, okay? So I'll find one that works. And it worked really hard to find one that works before we started. Cool. We'll find one. So a soft mist inhaler, when you click it like that, it just kind of makes this, kind of floats aerosol into the air, okay? So small volume nubs is like a large volume nub, but in a very small space, okay? Shoots out, has to be sucked out, gently comes out, okay? So, these all require different breathing techniques to be effective in medication delivery, okay? They all require different breathing techniques to be effective for medication delivery. So that means you need to understand your device, how it's used, and then the breathing technique to match the device for the person, okay? All right. Now, all nebs, as a general rule, only require you to breathe in and out. That's it, okay? No special breathing pattern. Occasionally we'll ask patients to take a big deep breath, but for the most part, we're just like, hey, just breathe through this, take an occasional deep breath, not a big deal, all right? So very easy to use. We use them on every single age group, all right? Okay, so the next page should be some pictures. Do you guys have the pictures? Everybody should have the pictures. Okay, so we're gonna go through. You guys all know what this is down here at the bottom. What's this one? For what gas? Can we presume? For oxygen, because it's got a green dial on it, right? Because we never believe the color of the Christmas tree or nipple adapter, right? It's always the dial or whatever it says. This is green, so it's oxygen. Okay. This up here, this one is what we call a T-piece nebulizer, and it's attached to a compressor. So a compressor you turn on, it's a motor. It pushes air through the device to help it work, okay? This one here is what we call an electronic vibrating mesh nebulizer. The one we use is called Aerogen. You can see it up here in the corner, A-E-R-O-G-E-N, Aerogen. Okay, so these are just some of what they look like, right? All right, the next slide. This is a pressurized MDI, okay? So remember I told you these shoot out. They create a spray at you, okay? And this is kind of a diagram of what that looks like. So we have the canister, that has the medication in it, and it sits inside what we call a boot. Do you have this? Yeah, okay. You make me nervous when you're like flipping around the things, like, oh, is she looking for what we're at? Every single MDI that shoots medication out will would and should always be used with what we call a spacer, okay? Always. I have a very hard time coming up with an exception to this rule, okay? Is this true in modern day life? No, but as a respiratory therapist, it will be true for you, okay? Any inhalers are always used with spacers. We can use inhalers for any sized person. Babies, kids, adults, old people, they can all use inhalers as long as we teach them correctly, okay? So this is a commercial inhaler that he's using, but you can see here she's using like an old pop bottle, okay? She's improvising. All right. This is what a dry powder inhaler looks like. Okay, so remember I told you dry powder inhalers, you have to suck the medication out. Okay, so there's a few different devices here. This is a very common one down on the bottom right. It's called a discus. And on the inside, you can see that there's a foil wrap here, okay? That foil wrap has what we call blisters. These are called blister packs medications, okay? These three. So on the medication, or on the, foil it's like this, it's flat, and then there's like little blisters full of medicine, okay? Medicine's in there. When you open up and activate the device, a thing comes through and cuts this open, okay? And then you suck the medicine out of the device, okay? So that you can see how as you progress through, then it just advances to the next one, okay? All right, so that's how blister packs work, or dry powder inhalers work, okay? This is still called a blister pack, but you have to take the medication out of the blister pack and put it in the device to use it. So it requires multiple steps. And we have all of these, you can play with them. This is what we call a turbohaler. You like these words? You all should have gone into pharmacy because you could have named everything so much better. Okay. A turbohaler is one that we twist. So we twist the bottom, it loads the medication, and then you suck the medication out of the device. Okay? So dry powder inhalers, we have to suck the medication out. A soft mist inhaler is like this. These are the ones I couldn't get to work right now. But this medication is loaded in the device, and it's under spring compression. So every time I twist it, I put pressure on the spring, and it loads a dose into the mouthpiece. Then I hit the dose release button, and it comes out, okay? So soft mist inhalers, you use them on their own. You don't use a spacer, and you don't have to suck it out of the device. It comes out nice and gentle. Okay, so those are the 4 major categories of devices that you'll be working with. All right. Now, when you take medication, how much of the medication do you think you actually get? Like if you swallow a pill, do you get 100% of the medication? Mm-hmm. No, how much do you think you get? Because there was a couple, yeah. I mean, like it's in my gut, right?
I don't know.
It depends on, yeah, it really depends on what it is, like absorption, right? How you process it, where does it get metabolized, all that types of things, okay? Now, if I told you that some devices that you breathe on only deliver 50% of the medication, that might seem like a little bit of a waste, right? Like, well, you just gave me a big dose of medicine, but only 50% of it actually got to me. It's really not much different than the drugs that you take orally, depending on what you're taking, okay? All right. So how do we increase deposition? Because deposition means this. Is it getting to my target? Okay, am I depositing it where I want it to be deposited? All right? So deposition really depends on the device you're using, the technique the patient and the therapist use in education to make sure it's taken correctly, the drug that you're delivering, which we talked about, and then the type of disease you're treating. All right? Those are the 4 big things that impact how well drugs are deposited, okay? All right, nominal doses, meaning like what's the base dose that I deliver, really varies by the device. So, example is albuterol. If I use an inhaler for albuterol, which looks like this, but it's typically red or blue. Okay, albuterol, one dose, one puff is worth 200 micrograms, okay? Sometimes, it seems high, I think it's 90. Cross that out, put 90 right there. I'm fixing that right now. That's not right. Fixing it right now. Okay, fixed, it's 95, 90, it's 90. So every time I hit a dose, I get 90 micrograms of albuterol. But if I put it in a small volume nebulizer, the dose I'm giving is 2.5 milligrams, okay? So this should say 0.09 right there. Okay, that's what I should look at, okay? So if I'm using a nebulizer, I have to give, however many, what is that, like 9, 18, like a lot more, right? 5, 10, like 5 times the dose, okay? For the same effect, right? So these are equivalent doses in terms of treatment, but they vary because of how I'm delivering it, all right? So depending on how much I want to give you, pick, device varies. All right, so along the bottom here, this graph is telling us how well drugs are deposited based on how they're delivered, okay? So we'll go through this together. Over here is the percentage of the delivered dose that is deposited, okay? Percentage of that dose, okay? Along the bottom are different devices that we can use. So this is, we'll just use albuterol in this example. So the first one where it says PMDI, that's what we call a meter dose inhaler, like the one I just dropped on the floor. Okay, that's this one, all by itself. The next one is a meter dose inhaler with a spacer. So like that picture I showed you, the girl with the Coke bottle, okay? The next one is what we call a meter dose inhaler with a valved holding chamber. The valved holding chamber was the boy that had that, what I said was a commercial spacer. It's yellow, okay? It's called a valved holding chamber. And then so is the next one. The difference is one is static free and one is not, okay? The next one is small volume nebulizer, and then the last one is dry powdered inhaler, okay? So what we're looking at is where the drug deposits based on the device we use, okay? So anything that's blue, that's exhaled. So I delivered the device. The blue portion here is how much of the delivered dose was exhaled. The gray portion is how much of the dose actually remained in the device, okay? The red is how much remains in the mouth. And the green is what actually made it into the lungs. It's not very much, is it? So based on that, which combination is the best for patients when we talk about drug deposition of a medication?
The VHC. What
Yeah.
does that stand for again?
Valved holding chamber.
What's the difference between electrostatic and
I'll tell you in a second. This is the valved holding, and we have these, you get to use them, okay? Chamber. Okay, so they're, a non-electrostatic one is made so it doesn't collect static, okay? That would be like a commercial one. And the electrostatic ones can collect static. Now, the difference is how much medication it will keep inside the device. I don't think I've ever seen a valve holding chamber that's electrostatic. That's like old school. Okay. All right, so clearly your best option, right, is to use an MDI with a valve holding chamber. And now I just told you, because you guys are all gonna be badass respiratory therapists, that this is the #1 thing you're gonna recommend for patients above all. Okay, inhalers with chambers. Now, there's a difference between a spacer and a chamber. So if you guys go back to that slide with the kids on it, okay? A spacer and a chamber. Now a spacer doesn't have anything in it, you just shoot medication in it and it just like keeps the medication in like a straight path, okay? Cause you see how it sprays out like this? Okay, so in this young lady here, it at least bounces in the general direction or maybe sticks to the inside of the pop bottle, okay? In a valved holding chamber like this, there's one-way valves. So you spray the medicine into the chamber. It can't go anywhere because there's a one-way valve at each end. And it's non-electrostatic, so it doesn't stick to the side. And then the patient can inhale the dose. If they accidentally exhale into the device, the one-way valve directs the flow out and it doesn't go back through the chamber. Okay? You guys, huh?
What's the difference between just like putting it in your mouth and doing it
Um,
versus
This is the difference. When you put it in your mouth, let's see, what is 90 minus 12? 78. When you do that, 78% of your medication lands in your mouth.
why is that though? Like why? What's the difference between the vital holding chamber,
Valve,
holding chamber,
Yeah.
and just hit like you're still inhaling the same way? So why isn't it
but
going?
you're not inhaling. Cause so when I do this, I spray it right in my mouth,
Mhm.
right? And so because it sprays like this, but you're inhaling like this, it just lands in your mouth. So every time you took your medicine and you're like, tastes bad, that is not where we want your medicine to be, right? Cause this, if we choose albuterol,
Mhm.
albuterol is supposed to be right this way, down in the lower airways, right? We can't taste our lower airways. Okay. So when it comes out super fast and like at an angle, it just sprays into your mouth. In the valve holding chamber, it sprays into the chamber, and even though it sprays out like this, because it's non-electrostatic, it doesn't stick to the chamber. It just like bounces around, and then it gets held still. It floats in the air, in that chamber, and then you breathe it in, and so you get this big dose. Okay? You guys get to practice with them, so you can show it. I'm sure you guys have found them. There's like a whole drawer of them, right?
Where do you get those chambers from?
You get them from the pharmacy usually, but they're super expensive, and so that's why people don't have them, because they're really pricey. This is what they look like for
So they
adults.
don't come with your computer?
They should, but they don't. Oh, that one's missing a mouthpiece, but
The only time I ever got one
See,
is
look,
when
they
I got
become-
pneumonia on top of it.
they come like for babies with little masks on them. But you'll see, you can share that one, these are different. You can see there's valves in them, right? So if a patient breathes in or out of it, remember yours is missing a mouthpiece, but breathes in or out of it, there's a duct valve, and so as they breathe in, that valve opens and pulls the medication through the chamber, but if they exhale, that valve closes and exhalation is diverted through a separate outlet. Cool? So, I don't care what age your patient is, when they're going home from the hospital, the best option for them is inhalers with a valve holding chamber. Your hospital will carry valve holding chambers, you just have to speak up if you don't have them, okay? It is the best way to treat patients.
And we giving them out for free, or they have to get them from their pharmacy?
Girl, you're gonna give that to that patient. You're like, here's your valve holding chamber. Take that home with you, okay? Insurance doesn't pay for them, they're very expensive, they're like $60, $70 at the pharmacy, okay? So if you have them at the hospital and your patient's going home with MDIs, remember they only work with inhalers that spray into the air. That's the only ones you're gonna use it with, okay? All right, and then look at the neb. So down here, remember at the neb, a lot of that gets exhaled because we're running it pneumatically, so it runs continuously, right? So it's not being delivered only on inhalation. And then the DPI, the dry powder, the one you suck out, right? A lot of that medication lands in your mouth. All right.
That's crazy. I didn't know that. I've
Yeah, I
never
feel like
heard
this
of
is
those.
not that common.
Right,
Yeah.
it's
Why
not
is it
uncommon
okay?
for new RT students to be like, never seen these. Even those with asthma are like, never seen
It's
this.
just crazy that they
yeah.
don't provide that for like people that need inhalers. Because I've always seen like, you
Just
know,
right
like
in that.
suck
Yeah,
it
my
in.
brother, yeah.
And you can do that, but look at the difference
Yeah.
in medication delivery.
And
The-
you take the medicine
The
more
only
often,
time I was ever
That's it.
given this one was when I had pneumonia on top of it.
Yeah.
And then they were like, oh yeah, we'll make sure to give you this. And I don't know why I never.
My brother had it when he was little. Like he had one with like teddy bears on it,
Yeah.
and he stopped using it because I think they we probably still have it somewhere in the house, but I think they like told him, yeah, you don't need it anymore. But like he still uses
you
an
do.
inhaler, like
Right.
normal. Like he still
So,
uses the.
Without it,
More is getting
and this is with the
yeah.
best technique. I mean, this is best technique straight in the mouth. So that's less than 10%. And if I just put a valve holding chamber on it, I get more than twice that. Right? So like you said, Tarika, I just need less medication when I do it properly, right? I feel better and I need less medication.
Yeah, because then I would have to hit my inhale like 3 times just to feel like relief. Who
Yeah.
knew?
Who knew, huh? All right, look at that, getting educated. All right, so aerosolized drugs, what's really great about them and what isn't? Well, what's really great is we have what we call lower systemic doses. So that means less of it goes through your body, right? Yep, who we calling?
Nobody, I was searching something on Google.
All right, so we have a lot faster onset than oral dosing because we're going directly to what we're trying to treat, okay? So we get direct delivery to the lungs, and fewer systemic side effects, and obviously less painful than any injection you're gonna get, right? Agreed? Okay. Some of the disadvantages, like you saw in the slide before, okay, is deposition can be very low, particularly if your patient has poor technique, okay? So even with the best technique, if all you're getting is like 8% of the medication, if you're delivering it straight in your mouth, poor technique is gonna give you what? Like next to nothing, right? Okay. A lot of variables can impact your deposition, requires some form of coordination, unless you're using nubs, which really doesn't. And poor education and knowledge is the #1 reason people quit using their inhalers or find them ineffective. Okay, poor education and knowledge. Guess whose job that is? Yours. Okay, and then of course, if patients have a lot of devices, that can be very confusing. Pills are pills are pills, right? It's not confusing to take a pill, it's just how many you take. It's really confusing when you have multiple devices at home and you have to use different breathing techniques for each one, okay? So your job as an RT, right, is to provide education and confirmation to your patients so that they know what they're doing. So what are some questions you might ask your patient about their inhalers or medicine, do you think? How would you confirm somebody knew what to do with this or what it even was?
Show me
Ask them to show me how to use it.
Yeah, can you show me how you use your inhaler? Cool. What else?
I mean, you could. No, go.
It's so what?
Funny.
Why?
Did I see a video or I think I saw a video and the guy asked her, how do you use your inhaler? And she like straight up like this.
That's on House. That's on House. It's one of my favorite videos ever. Cause she's like, my short use of breath is not getting any better. He's like, show me how you use your inhaler. And she's like, I don't know.
Oh my god.
Straight up it happens. I had one lady show me, I go, okay, show me how you use your inhaler. And she had a chamber and she goes like this. And I'm like,
Oh my gosh.
you inhale, like you took all the breath in, you sprayed it, and then you removed it and exhaled. So like all the medicine is still in here. And she's like, she got so mad at me. Don't you tell me what to do. I've been doing this for 30 years. And I was like, and you have not received a single dose of medication in 30 years. Like, what? She was not going to hear it. So we switched her to nubs, and she felt much better, oddly. I know, it's crazy. All right, so that is actually the very first thing you can do is be like, hey, show me how you use your inhaler. You know, and if they have great technique, perfect, good. And they'd be like, awesome. Why? Because people will come in, remember that people aren't at the hospital because things are going well at home, right? They're there because their home stuff isn't working, right? So part of your job is to be like, okay, do you use your inhaler? Okay, does it work? Like, do you feel different when you take it? And when they show you their spray in their neck, you'd be like, well, okay, well, you're not gonna feel any better, right? So that's the #1 thing, like, show me how you use your inhaler. What's the second thing we can do to confirm knowledge?
I guess breathing pattern. Ask like, when do you inhale? Like after doing it, unless that would be.
That's part of like showing me, okay.
How often do
Is
you
it like, do
do
they
it?
know what they using it for?
Yeah, okay, so how often are you using it and do you know why you're using it? So some of those questions are very vague, like how often do you use it? When I need it. Guaranteed that's your answer. When you ask somebody, like, when do you use it? When I need it. Great, when do you need it? When I'm short of breath. Perfect. How often are you short of breath? When I need my inhaler. You're at a complete loss, okay? So get better? Like, what else can we ask?
How many times a day do you use it?
There you go. How many times a day do you use your inhaler? How many inhalers do you buy every month? Tell me about your symptoms when you use your inhaler. What are you participating in when you feel like your inhaler is helpful? Okay, you have to get specific. I swear to God, you're gonna have this circular conversation. It's like, take a deep breath, and they breathe in and hold their breath, and you're like, exhale.
So, when they take it, are they supposed to cough? Because I see a lot of people coughing after.
Yeah, some people cough just because they took a deep breath for the first time that day, and they're like, oh, and it helps move secretions and stuff like that. So it's not totally uncommon. All right, so show me how you use it. Correct any errors they're making. You guys are gonna practice this, okay? Show me how you're using, correct any errors. Tell me about which medication is this? Oh, that's my puffer. Yep, but what medication is it? What's it for? What does it do? Do you know what it does to you? Okay? It helps me breathe better. And you can use really simple things like, yes, it helps relax the muscles in your lungs, or it helps reduce the swelling in your lungs, right? Whatever the medication does. Those are kind of your two big options, okay? All right? When do you use it? What do you do when you're done using it? Where do you store it? Right? All these things we'll cover, okay? But you can't ask like, when they say like, when do you use it? And they're like, when I need it. You have to remember, like, okay, yep. Now they tell me I have to be more like, how many times a day? Right? The other like side tangent I'll give you is that you can typically get 2 inhalers per month, okay? And so when you're working with of albuterol, and so when you're working with pediatric patients or those patients that use albuterol, remind them, you can get 2 inhalers per month, so order them every month, and then you have them in your car, at mom's house, dad's house, at school, in your backpack, in your purse, in your whatever, and then you rarely run into, I don't have my inhaler, or it's at my dad's house, or, you know, that kind of thing. So that's kind of my side. Okay. What are some of the hazards to patients by giving medications? Well, oddly, when you inhale a medication, you might actually cause bronchospasm, okay? And that can be because what you're inhaling is cold, or your lungs are just really hypersensitive, okay? Drug concentration can become an issue. When we aerosolize things out of a small volume nebulizer, the drug concentration or the fluid in the cup becomes more concentrated the further down the line you go, because you evaporate out the water, but not always the medication, okay? So sometimes we can get very concentrated medications being delivered to patients. There can be some infection risk if you're sharing aerosols, or if the aerosol's up for a long time. And some medications, this one in particular, why erase it? The duoneb or the ipratropium? I'll rewrite it. Ipratropium. This can be irritating to your eyes and actually cause dilation of your eye, okay? So you guys all put masks on the mannequin or yourself at some point, right? What was one of the #1 rules when you had a mask on?
Don't let it
Go
go
to your
up their
eyes.
nose.
Yeah, don't smash their face,
Yeah,
that's a good one
what I
too.
thought you-
But
No, it
don't
doesn't.
let it what?
Go to your eyes.
Yeah, don't let it blow in their eyes, okay? And that's gonna be true for your aerosol devices too, is that mask has to be nice and snug across the bridge so nothing's blowing across the eyes. All right, what's the hazard to you? Well, you don't wanna breathe in secondhand drugs, okay? Especially if they're sick and they're exhaling medications like with the neb. So while they're doing neb treatments, oftentimes RTs will wait over by the computer, or they'll have a mask on or whatever. Now, clinically, there are a lot of therapists that will go and they'll have 5 patients to see, okay? But we'll pretend you're the 5 patients and you're all in your own room, okay? And so what will happen is, because there's not enough therapists, is like, I'll walk into Terica's room and start the neb and be like, see you later. And then I'll come back down here and start her neb and I'll be like, see you later. And then I'll go start yours, and then I'll go start yours, and then I'll go start yours. Am I even knowing what's going on with her? I don't have a freaking clue. So I'm gonna go back over here, and by the time I get over here, she's holding it, and she's done with it, and like, I have no idea what happened. If she coughed, if she had a good reaction, did she even take the medication, right? I don't know, because I left. But I had 5 people to see, okay? I promise you your preceptor is gonna do that. And I promise you it's illegal and it's against your license law, okay? So as a student, because you can't look at your preceptor and be like, you're breaking the law, okay? That doesn't go over well. As a student, you say things like, I'll stay with this patient so I can see it from beginning to end because I'd like to practice, right? Cool, yeah, cool, stay here, I'll be back. and they leave and go see the 4 other people, okay? Because what are you doing in the meantime? Monitoring your patient, discussing medications with them, completing your charting, listening to breath sounds, making sure they don't take their oxygen off, okay? Then when you're a practicing therapist, I can't control what you do as you practice, but when you're a practicing therapist, you won't go see multiple patients at the same time, okay? One at a time. That's how it works. Can you imagine if your doctor pulled 5 people in a room and was like doing exams? Like, no. Okay?
So what if they say like no?
Then you just do whatever they ask. And then you tell me.
But how can it be preceptors if they don't do what they're supposed to do?
Yeah, I feel like you've said like
So,
4 times already, like
I'm
they're
just
not gonna do that, but you should.
I'm just trying to prep you because when I came here, I was, I'm gonna be real brutally honest with you. When I came here, the care I saw across the street is terrible from the RTs. I was appalled, and I went to Dr. Z and I was like, I'm sorry, I can't fix this. Like, this is terrible. And he's like, no, we have to fix it. So there's gonna be 3 sets of graduates in front of you with my little bit of infusion of like, we can be so much better. We're so much better than what's over there. You can provide amazing care to 1 person at a time. You know, and how do you do it? You communicate and you're honest with your patients, right? I'm sorry I'm here to see you late. I had 5 people in front of you. I need my neb right now. The great part about being 5th is that you're the least sick, right? There's 4 other people here that need a knee before you. Is you can be honest, right? Yes, I'm late. Or you start earlier and you say, sorry, I'm early. We've got a lot of people to see. I want to make sure you get your medication, right? It's all in how you manage your patients and their expectations, all right? So there's not anybody you're gonna see in the fall, or shouldn't be, that is critically ill, right? Your whole fall is about patient assessment, learning to talk to patients, and learning these basic therapies that you're gonna do forever and ever and ever. So when they leave you, when you're like, can I just stay and see it from beginning to end? Be like, and they're like, no, come with me. Be like, that's fine, do whatever. But advocate to do the right thing. And then when you're done, and when I send more students to you, do the right thing. Okay? You just have to be better. That's all I can say. And I know I say that a lot, but that's feedback I've heard just in the past 2 years.
I don't think you're wrong. It's just sad that is true.
It is sad,
It's
right?
It's
It's really sad, which is why I'm always like, okay, be prepared for this, and then this is how I need you to do it later. Because these people, like I said, they're not at the hospital because they want to be. They're not there for fun, okay?
And then they'll be like, oh, this is not the way to do it. But, you know, like, oh, don't you think this way to do it that way?
The preceptor? Sometimes they are, just smiling now.
Mm-hmm.
In Minnesota, the people would call me and they're like, your students are so slow. And I said, I don't care, because they're doing a good job. I'd much rather have people be like, your students are slow. Why? Because they went in and talked to patients and did a good assessment and did a therapy and did a reassessment and charted accordingly. Like, that's what you're supposed to do. They're just doing their job well. I'd take that 100 times over like, hey, your new student just managed 13 vents on their own. Okay, well that's bad care. Nobody can manage 13 vents on their own. Like, that's just ridiculous. I wouldn't even do that. And I've been in the game a long time, like, not gonna do it. It's not good care.
But like, I missed something, no.
Oh, absolutely, absolutely. So don't ever worry if they call me, and I'll always have your back. So if you're like, I'm not comfortable doing that, or if something doesn't feel, let me know. I do have an anonymous option for you, so if you have a significant concern, but you don't want to need to know it's you, you can submit it anonymously. I don't have any idea who submits them. And then I get information and I can follow up with the facility. And you can choose whether or not you want me to close the loop with you on there. You can be like, yeah, let me know, or not. So there's lots of options for you to communicate in that manner. All right. So yes, I say it, but it's more to have you ready, right? To be like, okay, Molly says it's gonna happen. All right, we're gonna quit at 2:30, deal?
Yep.
Okay, small volume nebs, so some advantages, disadvantages. There's a lot of drugs you can give in a nebulizer, lots, and you're gonna give a gazillion nebs, okay? Lots of medications could be mixed together, so that's good, right? You take like ibuprofen and Tylenol together. Okay. The patient doesn't really have to do anything except breathe. They don't have to talk to you. They don't have to have any special timing or technique, they just have to breathe. We can do it for any age group, same as inhalers. We can modify drugs the dosage much more easily than if we're using an inhaler, which is the same dose every compression, versus this, I can turn it on and off or dilute it. There is some variability in performance, and I would like to ask, based on this information here, why you think having variability in performance across devices might be helpful,
If you're treating a different area,
such as?
like if you are trying to get to like the bronchioles or whatever, you don't want it to be like the one that stays in the mouth. That's like,
So we're talking just nebs,
oh,
so just air, just like psh, aerosol.
oh.
You're not wrong though. You're right. It's all about where do I want the medication to land. Okay. So I might want medication to land to treat my stridor, right? We see epinephrine. Where does stridor happen? What part of the body? It's at the glottis. Okay. It's supraglottic, so above the glottis. Okay. Where does bronchospasm happen? Yeah, in the bronchioles, right? Lower airways, right? So these are two different places. I want to use the right device to get the medication in the right space. Okay. All right, normal breathing pattern can be used, that's fine. So the disadvantages is some treatments can take as long as 25 minutes depending on how much medication you have in there. Some equipment can be cumbersome. You have to have some form of power source, either air or an air compressor, or oxygen, depending on what you're doing. You need compressed gas, we'll say that. You can get drug in your eyes. You have to clean it, and it can get contaminated, right?
On average, how long would you say you spend with a patient when you're giving them a treatment?
Just a singular treatment, probably 20,
It's just like in general. I
probably
guess.
15 to 20 minutes, depending on what they're doing. Are they well organized, or is like breakfast in the bed with them? See what I'm saying? Are they in the bathroom? Cause then I gotta come back. So I would say probably 15 minutes from the time you walk in, introduce yourself, do your assessment, do your treatment. While your treatment's running, you can chart your assessment. Usually by then you have an opportunity to kind of talk, especially if they're just doing a neb, to talk with them, you know, about what the plan is or how they're feeling or whatever, clean everything up and get out. If it's just an inhaler, it might be 10 minutes, just depends. Alright, so this is what the little jet nebulizers look like. This is what we call a T-piece nebulizer, okay? This is the T right here, so this is the mouthpiece at the end where the mouth is. This is, what kind of tubing do we call this?
Corrugated.
It's corrugated tubing, and why did we put it on the T-piece for the trach patient? What did it act as?
A reservoir.
It's a reservoir, yep, so we're gonna call it the reservoir tubing, okay? It's a reservoir tube, it is made out of corrugated tubing, you are correct, okay? This is the neb here, the neb, kit, or the medication bottle, and then tubing. They'll call it oxygen tubing, sometimes it's called compressed gas tubing, but either way. Okay, so what happens? Well, this is like 3 pieces right here. So here's the mouthpiece on this side, okay? And then over here is where the reservoir tubing would be, okay? And then these little rough sides right here is the top and bottom difference. And this opens up, so you untwist it and it opens up, and you squirt medicine in the bottom, okay? All right, so this is called the reservoir. There's medication in here, and the compressed gas comes through this tube, okay? And it sucks the medication up the capillary tube, and when it sucks it up the tube, it hits what we call the baffle, and the liquid hits the baffle based on the jet power of the air and goes, and like explodes into an aerosol, okay? The aerosol that falls down into the cup cannot be inhaled or exhaled, so we call that dead volume. I can't do anything with that, okay? But the aerosol that travels its way up into the mouthpiece or the reservoir tubing, this is all inhaled, okay? Now this type of T-piece nebulizer runs continuously, so that means despite the patient's inspiratory or expiratory phase of the respiratory cycle, it's creating medication, okay? It's running. So if you go back to that bar graph we made, you'll see a lot of it is just lost to the air, okay? And that's because it runs all the time, all right? All right, jet nebulizers come in many different sizes. So these are some up here, but I'm gonna throw you. Well, I gave you guys a nub kit, didn't I? Didn't I give you all a nub kit?
Yeah.
Yep. Okay, but they look like this. You guys can open these if you want. Ready? That's your face. Okay. Oh, I hear people dropping pieces. All right, so you should have a top and bottom, and then there's like a green green piece on the inside. Is yours green? And is it It is. Okay, so yours is upside down.
Mine's sticky.
Is it sticky? Is it just the tubing that's
Yeah.
sticky? Okay, don't touch the tubing.
Okay.
It's because they're so old. I told you when I got here there was like 9,000 of everything, and I'm like, how long have you had these? So like several years. I'm like, gross. Okay. Yep. So you can unscrew it, right? So the green kind of piece doesn't come out, but if you look at the bottom, you got all sorts of stuff.
I think that's just on my little brother.
Oh my goodness. Here, you can put just a little bit of saline in there, and you'll see that it goes underneath that green piece. This is upside down. There you go.
Wait, this is out of here.
So
And, like,
open it.
squirt it like
You
into
think that's
the.
in the
Nope,
bottom?
nope.
No.
Open it up.
Yeah.
Open it up. Take the
No,
top
but my
off.
thing, this not open, not at the bottom. 'Cause I don't
It
want to
screw
look at
like
it.
unscrews. There you go. So
Put
you
it
should
into
have.
this.
Yep, you should have the clear
Why is that
piece.
at the bottom?
All right, and so you're gonna put it in there what we call aseptically. So you don't want to touch the inside of the nebulizer kit in any way. Okay, not with your thumb. Did I throw saline at you? Okay, good. Not with your
Put the whole thing in
medicine.
there?
No, just a little bit.
No, I didn't.
You did? It's fine. You don't have any reservoir tubing, do you? None of them came with reservoir tubing. That's fine. You can put it in there.
All of it.
Doesn't matter. Did you put some in there? Okay, so now when you lift it up, don't tip it, but when you lift it up, you'll see there's fluid on top and underneath that green piece, right?
Oh, yes.
Yes?
Slightly.
It's clearly above it.
Yeah, I don't see anything.
Yeah, mine's above.
Oh yeah, there's some underneath there.
Oh, like physically under.
Yeah, physically underneath it. Okay, so what happens is as the gas flow comes through the bottom, right, it creates a vacuum, right? Because high pressure creates vacuum, yes? Okay. Or low pressure creates a vacuum, but high velocity creates that low pressure, agreed? Okay, so as we shoot gas through there, it pulls the medication underneath that green ledge and brings it up the inside of it and smashes it against the baffle. And the baffle should be on the inside of the opaque
Like this
piece.
fourth, that three.
Yes, that little Mercedes looking sign, okay? It's on the inside of this. It's on the inside of that. So you take it off and look at it, see?
Oh.
Yep, so that's the baffle. So it hits the baffle and it goes whoosh, and turns into an aerosol, okay? And then your patient breathes on one end and the medication goes in and out the other. Excellent news, right? This one's not sticky. Oh. This would be the aerosol tubing. Kits come with aerosol tubing, okay? So once y'all come back here, I will find some tubing. Get a flow meter, bring your notes with you. One, two,